Headache may be the most common neurologic complaint in the adult population, if you can call headache a neurologic complaint. As much as half the adult population has headaches, mostly migraines and tension-type headaches, and 2 to 4% of all adults have headaches more days of the month than they don't have headaches. Collectively, headaches are the third most common cause of years lost to disability, and besides creating a physical problem for these patients and burdening them financially with days lost at work, they're also stressful. Even when a patient may be headache-free, there's often the anxiety of, when's it going to happen again? The trigeminal autonomic cephalalgias, or TACs, represent a unique class of primary headache disorders with a predictable pattern and characteristic autonomic symptoms, but that doesn't make it easier to recognize them.
Trigeminal autonomic cephalalgias are very commonly missed and misdiagnosed.
If you don't screen for the autonomic symptoms, or you don't focus on the frequency and the duration of symptoms, you may not figure out the pattern. Many clinicians may neglect these critical headache features and focus solely on the severity of the pain.
Cluster headache is the most painful headache disorder of all primary headache disorders.
But if you treat a cluster headache like you would treat a tension headache, it's not going to help much. And your patient's going to return with more and more headaches. The pain will keep them from enjoying life, and it will keep them from returning to work. And all you're doing for your patient is exposing them to medications with more and more side effects. Welcome back to Brainwaves, a podcast about neurology and medicine, and all the fascinating science and history that come with it. I'm Jim Siegler, and this week on the program, trigeminal autonomic cephalalgias.
There is cluster headache,
paroxysmal hemicrania,
the two short-lasting unilateral neuralgiform headache attack disorders
called Sunct and suna,
and there's hemicrania continua.
What to know about these disorders, what not to miss, and what to do when you recognize one of them. Stay with us. Hey, Dr. Kuruvilla.
Hi, how are you?
I'm good. How's it going? For this week's program, I got to speak with Dr. Deena Kuruvilla, a headache specialist at Yale.
My name is Deena Kuruvilla. I'm an assistant professor of neurology at the Yale School of Medicine.
She was fellowship trained in headache and facial pain at the Montefiore Headache Center and at the Albert Einstein School of Medicine.
I'm also a guest journal editor for Practical Neurology and news editor for the American Headache Society.
In addition, Dr. Kuruvilla serves as a consultant for Lilly and Amgen, two pharmaceutical companies which produce CGRP monoclonal antibodies that are used for the treatment of migraine. And before we even had these revolutionary treatments for patients with headaches, Dr. Kuruvilla knew she wanted to study headache medicine.
I find that headache is a very treatable condition. And when you have patients that are relieved of pain, they're just so thankful and so happy.
And Dr. Kuruvilla also feels a more personal connection to her patients and recognizes the value of the treatment that she and others can provide.
I actually have had a migraine myself in the past, and so I can totally relate with patients on how painful headache disorders can be as well.
And if you haven't had a migraine, they're so common, so I'm sure that you've come across plenty of patients who've had them. And they're one of the 4 primary headache syndromes that can lead to a chronic daily headache. One of these 4, hemicrania continua, is also a trigeminal autonomic cephalalgia. And we'll talk about that condition in greater detail in a minute. But first, I spoke with Dr. Kuruvilla about what the trigeminal autonomic cephalalgias are and what it was that differentiated them.
So to start off with, there are 5 trigeminal autonomic cephalalgias. There is cluster headache, there's paroxysmal hemicrania, there are the 2 short-lasting unilateral neuralgiform headache attack disorders called Sunct and suna, and there's hemicrania continua. They all have episodic and chronic forms except for hemicrania continua. The duration of the attack, as well as the treatment for these separate conditions, are what differentiate the different types of trigeminal autonomic cephalalgias.
So while there are a lot of similarities between each of them, as you're going to hear, if you think about each of these headache syndromes by their duration and their drug responsiveness, that tells you which one you're dealing with.
Anytime you see a patient with a strictly unilateral headache and it's associated with ipsilateral cranial autonomic features, a TAC should be considered.
TAC, as in the shorthand for trigeminal autonomic cephalalgias.
Cranial autonomic symptoms typically include lacrimation, conjunctival injection, rhinorrhea, nasal congestion, eyelid edema, sweating, flushing, miosis, and orthosis. And of the TACs, cluster headache is by far the most well known.
It also happens to be one of the most common and the most severe of all the TACs, maybe even more severe than most other headaches in general.
The vast majority of cluster headache, also known as suicide headache, are extremely severe.
If somebody has no history of headache and they come in and they've got conjunctival injection or tearing, and maybe they've got some other ocular complaints with a headache, as an inpatient hospitalist, I feel almost compelled to image these patients. So kind of reason with me why you would or would not image somebody for this.
Absolutely. So it is important to always rule out a secondary headache disorder before you diagnose a primary headache disorder. There have been case reports of the TACs presenting with an underlying tumor, aneurysm, or a dissection.
And we see this all the time: sudden unilateral headache or neck pain with ipsilateral meiosis and a carotid dissection due to injury of the sympathetic plexus.
Some of the other reasons to potentially image a patient include to look for sinusitis, a demyelinating disorder, orbital pathology, or dental pathology, just to name a few other secondary causes for these headache disorders. So whenever I first evaluate a patient with any side-locked headache,
side-locked meaning that the patient only experiences the headache on one side. The TACs don't often alternate sides, like in a migraine.
I obtain an MRI brain with and without gadolinium and vessel imaging of the head and the neck with either a CTA or an MRA of the head and the neck.
Moving on to the pathophysiology, it seems that all the TACs are a product of this enhanced trigeminal reflex. What do we know that functional neuroimaging has told us about this circuitry, and how does this impact patient care?
So, unfortunately, the pathophysiological basis for TACs are not well understood. We know from functional imaging that there is an activation of the posterior hypothalamus.
In the setting of a cluster headache, the posterior hypothalamus, or the ventral tegmental area, this region lights up during functional MRI. Now, what this means, whether it reflects a spontaneous central pathophysiologic activation, or if it acts in response to other peripherally triggered spontaneous nociceptive activity, is unclear.
The role that the hypothalamus may play in the activation of TACs is pretty much unknown.
The thought that it may activate in an attempt to suppress pain is supported by recent evidence that deep brain stimulation of this structure may actually reduce the risk of headache attacks.
A lot of research is still going on using these functional studies to identify what the connection is.
Then, of course, there's the trigeminal component inherent to all TACs.
So the cranial autonomic features we end up seeing with TACs arise from a well-described trigeminal autonomic reflex. Parasympathetic activation is triggered from the superior salivatory nucleus in the pons. Fibers from this location then pass through the geniculate ganglion and then synapse in the sphenopalatine ganglion, which in turn innervates the adjacent vessels, the lacrimal glands, and nasal mucosa, which explain those features that we end up seeing with TACs.
Which, as you'd expect, accompany the headache.
They usually happen during the headache attack.
So we have these conditions, 5 headache syndromes, maybe even a 6th if you count trigeminal neuralgia, which is on the non-autonomic spectrum of the TACs. More on that in a minute. We have these 5 conditions, and they are distinct in their duration and their response to certain treatments. So Dr. Kuruvilla and I got into more detail about that, beginning with cluster headache.
Sure. So interestingly enough, the age at onset for cluster headache is between 20 and 40 years old, and for unknown reasons, men are afflicted 3 times more often than women. The prevalence is around 1 per 1,000 person population.
Think of it in terms of how common multiple sclerosis is. That kind of common.
So around 300,000 Americans may have had a cluster headache at some point in their life.
And cluster headache gets its name for how the headaches tend to cluster over weeks or months throughout the year. And they tend to occur during specific periods of the year as well.
Cluster periods were most frequent in the autumn and least frequent in the winter.
An interesting finding that some have used in support of the hypothalamic pathway. In the summer and the fall, with ample light, there's plenty of activation of the suprachiasmatic nucleus of the hypothalamus. And maybe it's this that triggers the aberrant trigeminal pathway.
So usually these clusters, as we call them, are separated by remission periods, usually lasting months or years. But around 10 to 15% of patients don't have these remission periods, and they're classified as chronic cluster headache.
Chronic cluster headache, meaning that the patient has had remission lasting less than 3 months, but the headache comes and goes for at least 1 year.
Another thing that differentiates cluster headache is that the headache lasts from 15 to 180 minutes and occurs from once every other day to up to 8 times a day.
You might distinguish these temporal characteristics of cluster headache from paroxysmal hemicrania, which can occur as many as 11 times a day for shorter periods of time, typically 2 to 30 minutes, or the headaches associated with Sunct or suna, which, as their name suggests, are very short-acting, lasting only minutes, but occur up to 100 times a day. Another key feature of patients who have cluster headache, Dr. Kuruvilla says, is their restlessness.
So in my clinic, when I'm trying to differentiate, for example, between migraine and cluster headache, I often ask the patient if they prefer to lay down or do they prefer to pace and walk around the room during an attack. Because that helps me differentiate between those particular disorders, because during migraine, patients are usually disabled and want to lay down. And during cluster headache, patients are usually pacing around their room and they're agitated.
Regarding the treatment of cluster headaches, Dr. Kuruvilla thinks about it in 3 ways.
So once I've ruled out secondary causes for headache and confirmed that cluster headache is the likely diagnosis, I usually consider 3 types of treatment. I usually consider an effective abortive treatment, a preventive treatment, and a transitional treatment. The abortive options with the most evidence are high flow oxygen at a dose of 15 liters per minute through a face mask.
And you can do this for 15 to 20 minutes in your office or in the ED. Or you could try
subcutaneous sumatriptan and zolmitriptan nasal spray,
like you would for a patient with a severe migraine attack.
I think the one takeaway for cluster headache abortion is that oral medications are usually avoided because they take way too long to work in these attacks. The most commonly used preventive treatment by neurologists and headache specialists for cluster headache is verapamil, but usually patients need 360 milligrams or 560 milligrams a day to see a break in their cluster headache cycle.
You can imagine that with such high doses of verapamil, you might bottom out a patient's blood pressure, make them presyncopal, or even put them into heart block. So checking an EKG and close monitoring of their blood pressure is critically important as you're up-titrating this calcium channel blocker.
And I personally take extra precautions and have the patient follow with a cardiologist very closely as well.
For your patient who can't tolerate verapamil because they're getting dizzy, or you're worried about their EKG, or they're getting constipated, which happens with this drug, you could consider other therapies.
Other, decent cluster preventive options are lithium, topiramate, gabapentin, valproic acid, and melatonin.
While you're getting a patient onto this preventive regimen for cluster headache, Dr. Kuruvilla likes to give them a bridging therapy to support them until that regimen kicks in.
So the transitional treatments that I tend to use are really used as a bridge. So in the office when I'm evaluating them, I usually give them an occipital nerve block with steroids on the side of the pain, or I give them a short course of steroids at the same time, not with the occipital nerve block with steroids, but separately. Or I even admit some patients to the hospital and consider IV dihydroergotamine every 8 hours times around 6 doses, which can also help stop attacks in the transitional period.
There are also more options for refractory cases. For example, the FDA has approved the GammaCore device,
which is a non-invasive vagal nerve stimulator.
The safe and gentle electrical stimulation is delivered through the 2 stimulation surfaces.
It's pretty easy to use. It's a handheld stimulator that's used for the acute and preventive treatment of cluster headache.
And then there's recent data suggesting deep brain stimulation of the ventral tegmental area, or placement of a spinopalatine ganglion stimulator, may also be effective for chronic cluster headaches. Now that we've covered cluster headaches, let's move on to 2 other types of attacks, the Sunct and Suna syndrome.
Right. So Sunct is an abbreviation for short-lasting unilateral neuralgiform headache attacks with conjunctival injection and tearing. And suna is an abbreviation for short-lasting unilateral neuralgiform headache attacks with cranial autonomic symptoms. And basically, the main difference between Sunct and suna is the presence of conjunctival injection and tearing in Sunct.
Both Sunct and suna are short-lasting, again, only for minutes at a time. But like other attacks, they have some sort of autonomic disturbance. And despite being so short, they tend to be incredibly frequent, ranging from several dozen headaches a day to several hundred.
On average, the attacks in these patients occur around 100 times a day.
Unlike cluster headache, which can affect as many as 1 in 1,000 people, the epidemiologic data for Sunct and suna are less known. We don't have a good sense for how common they are, and maybe that goes to show how uncommon these headache disorders are, or at least how bad we are at recognizing them. We do find that suna is 5 times rarer than Sunct, and unlike cluster headache, the headaches in Sunct and suna tend not to cluster as clearly, and they're more common to be chronic headaches. But there's at least one other similarity to cluster. Both Sunct, suna, and cluster headaches are more common in men, at a ratio of about 2 to 1. And then you said that a major differentiator between the different attacks is treatment options. So, with cluster headache, it has its own treatment option. How does Sunct and suna treatment differ?
Yeah, so the first-line therapy that we use for Sunct and suna is lamotrigine. And sometimes we need doses up to 300 or 400 milligrams a day. So lamotrigine is really the only treatment that we have some minimal evidence for.
According to observational data, maybe about 2/3 of patients with Sunct or suna respond to lamotrigine.
There's also a little bit of evidence for using topiramate, so sometimes I consider that for prevention in these patients also. As far as acute treatment goes, sometimes these attacks are so brief, it's very difficult to break a single attack. But if you're trying to break, several attacks happening over a day, there have been some reports of intravenous lidocaine and methylprednisolone being used, and they really do have the highest odds of pain freedom after administration based on some limited literature.
You might think that it's the sodium channel blocking properties of lamotrigine or of lidocaine that give these meds their effect in treating the trigeminal neuropathology of Sunct and suna. But it's really not known how or even why they work.
The mechanism is really unclear. I've looked this up so many times over the previous years, and we have no idea why it works.
For some patients, as you're working them up for a recurrent side-locked headache with autonomic disturbances, you may also find something unusual about them, which has treatment implications.
We were talking a little bit about secondary headaches earlier in the conversation, but in Sunct and suna, you can find on your imaging studies that there may be compression of the trigeminal nerve by a major blood vessel, usually the anterior inferior cerebellar artery, or the superior cerebellar artery, or the vertebral artery.
And if you find that, these people may be candidates for microvascular decompression. So Dr. Kuruvilla will often refer her patients to neurosurgery if she finds this unusual vascular loop, just like you might do for a patient with a somewhat related facial pain syndrome, trigeminal neuralgia.
And, there is a part of the headache community that believes that trigeminal neuralgia is along the spectrum of some of the attacks. It's just on a different side of the spectrum, and it doesn't have autonomic features.
Makes sense. I mean, it's just the trigeminal cephalalgia, not trigeminal autonomic cephalalgia. In patients with Sunct or suna, who are refractory to lamotrigine or gabapentin, or occipital nerve blocks, or microvascular decompression, a more invasive approach has also been studied.
For Sunct and suna, surgical options such as occipital nerve stimulator placement or deep brain stimulator placement,
specifically in the ventral tegmental area,
can be considered in very refractory cases.
And in one case series of 11 patients who failed conservative management, the investigators observed an 80% improvement in attack frequency. And similar benefit has also been observed in patients with refractory cluster headache, as we talked about earlier. This data further implicates the role of the ventral tegmental area in attack pathogenesis. All right. So now we've covered episodic and chronic cluster headache, the Sunct and the suna syndromes, and this leaves us with the indomethacin responsive paroxysmal hemicrania and hemicrania continua. And there are a lot of similarities between all these conditions. So how do you distinguish paroxysmal hemicrania from something like cluster headache? And then when is it hemicrania continua?
So paroxysmal hemicrania and hemicrania continua are still a unilateral pain, headache pain that's usually orbital, supraorbital, or temporal, or any combination of these sites, and are still associated with autonomic features. Paroxysmal hemicrania usually lasts from 2 to 30 minutes, and it occurs more than 5 times a day. The average number of attacks a day for paroxysmal hemicrania is around 7 to 13.
Which is kind of a middle-of-the-road number of daily headache attacks for the TAC syndromes. More than the 1 to 8 attacks for cluster headache, but not in the potentially dozens or hundreds that we see with Sunct and suna. And the duration of headaches reported in paroxysmal hemicrania are commensurate with this frequency. Usually they last 2 to 30 minutes.
Hemicrania continua is different in that it's one of the 4 chronic daily headache disorders, as well as a trigeminal autonomic cephalalgia.
With the 4 chronic primary headache disorders being?
The most common is chronic migraine,
with the headaches occurring for at least 15 days per month, usually in a patient who has a history of migraine headaches.
And then there's chronic cluster headache,
which occurs in about 10% of patients with cluster headache and is defined by the recurrence of cluster attacks for more than 1 year without at least 3 months of clinical remission.
New daily persistent headache,
which is a really interesting condition. It usually affects people who've never had a headache before. It begins suddenly, and most patients remember the exact time it begins. And these headaches last 3 or more months.
And hemicrania continua.
Again, these are all the primary daily headache disorders, meaning they do not develop as a consequence of some other process, like medication overuse or musculoskeletal pain or TBI or something.
Hemicrania continua can have attacks or exacerbations as severe as cluster attacks, but between those exacerbations, they have this baseline background continuous level of pain.
And just to emphasize this point, like Dr. Kuruvilla mentioned earlier, the only specific way to distinguish hemicrania continua, or paroxysmal hemicrania, from any other type of TAC is by its duration and response to treatment.
So really the only differentiating factor is the duration and the treatment. Paroxysmal hemicrania and hemicrania continua are exclusively responsive to indomethacin at doses from 150 milligrams to 225 milligrams a day. Indomethacin is the treatment of choice and is basically a diagnostic test because technically, if you have hemicrania continua or paroxysmal hemicrania, you have to respond to indomethacin treatment.
With that said, you're probably wondering, if paroxysmal hemicrania and hemicrania continua are on the trigeminal autonomic cephalalgic spectrum of headache disorders, how would an NSAID work to suppress this abnormal circuitry? Well, it's a great question, and the answer is nobody really knows.
If patients are not responding to indomethacin at appropriate doses, then we really have to reconsider the whole diagnosis because they don't fit the criteria then for those diagnoses.
Great. Yeah, and that gets perfectly to my next question. So if you suspect a TAC, but the patient doesn't respond to first-line therapy like indomethacin or, I guess, oxygen therapy or lamotrigine or something like that, what do you do next?
Yeah. So that's a complicated question because there are so many different things that we do for all the headache disorders, unfortunately, that don't have enough evidence and oftentimes use treatments that are in an open label fashion just to help patients. In patients with hemicrania continua and paroxysmal hemicrania who don't respond to indomethacin, one might consider an alternative diagnosis like migraine or cervicogenic headache. Migraine in around 15% of the population can be side-locked. And so that might be an alternative diagnosis to consider. If indomethacin is cut, then other drugs that have some case reports behind them are Topamax or using a steroid in the acute setting. Lamotrigine, lithium, they have some minimal evidence and sometimes are used in practice also. And alternative NSAIDs that can be considered are rofecoxib, celecoxib, and naproxen, but they still have minimal evidence.
What Dr. Kuruvilla is emphasizing here is that when you suspect one of the attacks and you challenge them on the appropriate and targeted therapy, but they don't respond, you must consider an alternative etiology. If you haven't imaged the patient yet, this would be a good time to get a good quality MR of the brain. If you haven't identified a secondary cause of headaches, or maybe they do have chronic sinusitis, then this is when you should be entertaining those diagnoses. Also worth noting here is that, regarding treatment, not all headache therapies are perfectly benign. And for the treatment of paroxysmal hemicrania, or hemicrania continua, where patients are on a long course of indomethacin, or some other NSAID,
free for 4 to 6 months or close.
Dr. Kuruvilla puts her patients on GI prophylaxis
with Carafate 1 gram 3 times a day
in order to prevent gastric ulcer formation and reflux symptoms, which will definitely keep your patient from adhering to this treatment regimen. They'd basically be trading one pain syndrome for another.
It's just really important to start a stomach protectant with this medication. I see it started a lot of times without the stomach protectant medication, and then the patient ends up getting an incomplete indomethacin trial.
In some cases, patients may be refractory to these standard regimens, and they may require additional therapies. In our interview, Dr. Kuruvilla also spoke a bit about the future of TAC therapy, especially in light of recent evidence for CGRP monoclonal antibodies for migraines. As it turns out, these drugs may also be helpful in a patient with TAC.
And specifically, the two that are being evaluated are fremonezumab and galcanezumab.
Both drugs have proven efficacy in patients with migraine headaches, and there are currently about a half dozen ongoing Phase 2 and Phase 3 trials, the ENFORCE trial being one of them, evaluating these therapies for cluster headache.
CGRP, we know, is one of the main inflammatory mediators in migraine pathophysiology and many headache disorder pathophysiology. And so the aim of these drugs is to block calcitonin gene-related peptide to kind of slow that headache process.
One of the convenient things about these agents is the manner in which they're given. So, unlike topiramate or nortriptyline, which are pills that have to be taken daily, the CGRP antagonists are monthly or quarterly injections or infusions, so compliance is much less of an issue for these patients. Also, when you compare them to medicines like topiramate, which can cause mental fogginess or weight loss or kidney stones, the side effect profile for the CGRP agents is much more benign.
The most common side effect of all three of them is injection site redness, itching, and pain that's usually self-resolved. And with erenumab specifically, constipation occurs in 2 to 3% of people.
So pretty underwhelming for the most part. And given the enormous benefit we've seen in migraineurs, I think we have plenty of reasons to be optimistic about the CGRP antibodies in our patients with cluster headache. I also tend to prognosticate a lot when I'm talking with my patients. How can we think about what you're going to be like in 3 months, 6 months from now? What can I tell a patient to do to kind of prevent these things from happening again? Like, what kind of triggers can I tell them to avoid?
So to be honest with you, it's not what triggers that one can avoid with the TAC so much. It is tight follow-up to see how the patient is doing. There was actually literature that came out within the past couple of years that showed that patients with episodic cluster headache, when they went into remission after the first cluster attack period that they had, they stayed in remission because of close follow-up with their provider. So I think closely following up and monitoring patients on medication is the single thing that we can do to make sure patients are not going back into remission. For example, in cluster headache patients, sometimes they get a warning that they're going to have a cluster attack. They start getting a dull aching or a dull sensation, they often say, on the side where they get the headache. And so if we see any signs that that's going to happen, we preemptively start a preventive treatment.
Dr. Deena Kuruvilla. So that was definitely a crash course covering the various TACs, their clinical presentations, their subtle differences, and their selective response to treatment. But hopefully we can all be more prepared to recognize these headaches when we see them. Because, like Dr. Kuruvilla said, they take a little more effort to diagnose.
Trigeminal autonomic cephalalgias are very commonly missed and misdiagnosed. The reason being, many times patients themselves either will not report the autonomic features, or they just don't even know that the autonomic features are happening.
So it's ultimately up to you to tease out that level of detail from the patient. With that side-locked headache, have you noticed any blurred vision, any tearing, any redness to your eye, or stuffiness in your nose?
I've seen many patients who come to see me after they've had many consults with ENT because they thought they had a sinusitis for the previous 6 months to a year before I saw them.
That's just a crazy amount of time.
I think sometimes it's important to pick up these subtle histories from patients and also use your physical exam to diagnose this.
Use your history-taking skills, examine the patient, and probably image most of these patients to exclude a structural or a vascular cause of their symptoms. All right, well, thanks so much, Deena. I appreciate you coming on.
Yeah, no problem. Nice meeting you, Jim.
You too. Bye-bye.
Bye.
That wraps it up for another episode of Brainwaves. The Brainwaves podcast is produced out of Studio 3 in Philadelphia, Pennsylvania. I'd like to thank Dr. Deena Kuruvilla for joining us via Skype. Music for this week's program was courtesy of R. Sonor, Axel Tree, Kevin McLeod, Lee Rosevere, and Steve Combs. Sound effects by Mike Koenig and Daniel Simeon. As always, you can follow Brainwaves on Twitter or Facebook at Brainwaves Audio and drop us a line sometime. Let us know what you'd like to hear on the show. I'm Jim Siegler for Brainwaves. Thanks for listening.